this is the checklist before you start your assessment. Very important kasi in some cases, nag-start ka ng assessment, tapos along the way, na-realize mo meron pa palang kulang kay patient or hindi magiging effective ang assessment kapag hindi nagawa ito. So now, we have three things to consider before you do your assessment for your low vision patients. Okay, so number one, has the person's diagnosis been confirmed by an ophthalmologist or other eye care worker? Okay? So, in some cases, pupunta si patient walk-in, magpapa-assess for low vision assessment. Okay, sasabihin niya, Doc, may katarata po ako. Okay, or Doc, may ano po ako, glaucoma. Okay? Then, ang mangyayari, along the assessment, na-realize mo, either unreliable yung sinabi ni patient, or findings show that your patient is not low vision. So first rule, dapat yung condition has been confirmed by an ophthalmologist or by a reliable source from a hospital, from an eye clinic, eye center. So dapat reliable yung source. If the patient says meron akong glaucoma, for example, dapat may supporting documents. Okay? Kasi this will save you a lot of time kapag na-assess mo na agad. Next, has all the medical, surgical, and optical treatment possible already been given? The part of your definition for low vision, dapat nagawa na po lahat ng ito. Diba? Medical, surgical. So lahat ba? For example, if your patient has ARMD, what are the available remedy, medical and surgical for the patient? ARMD. For ARMD, age-related macular degeneration. Surgical, ano kaya? Pwede gawin? Let's say, medical, pwede maglagay ng anti-VEGF, no? Okay? Anti-VEGF, what else? Ano pa? Anti-VEGF, then, for example, may kailangan surgery, no? Meron images and all. Nagawa na ba lahat ng yun? Glasses, umubro ba? Hindi. So yun. Kasi diba, under definition, dapat nagawa na lahat ng yan and still hindi nag-improve yung vision ni patient. That's the time your patient is considered as low vision. And third, has the prognosis for vision been confirmed by a medical professional? Prognosis is very important. No? Before you do any assessment, you must have a good understanding of the prognosis. For example, naggawa ka ng assessment, management. You gave spectacles, you gave magnifiers, okay, electronic devices without confirming yung prognosis. Then, a month after, nalaman mo, nag-progress pala yung disease. Then, another month, NLP na siya. So, ano nangyari sa management na binigay mo? Useless siya. Diba? So, before you do any assessment or any management, it is wise to ask or confirm yung prognosis. Is the condition getting any better, stable, or worsening? Siya. Okay? Clear tayo dun, guys? Clear? Okay, so very important yan. Kasi if you skip this part, merong chance na pwedeng babalik ka pa or inefficient. So, practical advice, when you're in the practice kasi, as much as possible, we avoid being inefficient or yung inuubos yung masyadong maraming oras. Diba? Pag nag-assess tayo ng normal patient, gaano katagal na lang ngayon? Normal, yung normally sighted patient sa clinic, gaano katagal? Yung buong process. Ay na daw. Mga ilan na lang? Minutes na lang? Yeah? Minutes? Minutes na lang. Okay, good. But how about a low vision patient? Oras, okay? So yung normal assessment oras pa lang, paano pa kapag ka-inefficient? Pag yung tipong ay nakalimutan ko pala to, ay hindi pa pala dapat to, ay hindi pala dapat ginawa yung test or may kulang pa. So yun yung point doon, okay? Next, in assessing your patient, so start na tayo. So you will assess. Tayo. Kasi Pilipino tayo. Sa mga Pilipino tayo. Alright, so now, actually starting yung assessment. So when you assess a patient, okay, what are the things that you need to consider? Kayo, pagka nag-assess kayo, pagka andyan na yung patient sa harap nyo, ano yung mga usual na iniisip mo itanong? Ha? Case history yan. Magsa-start ka na ng case history. Ano kaya? Ano yung mga usual? Or paano ka mag-greet ng patient pagka nakita mo na siya?
Kamusta na ikaw?
Kamusta na ikaw?
Ano nangyari sa'yo?
Ano pa? Ano pa? Ano pa?
Ano yung reason bakit?
Ano yung reason? Ba't nandito ka? Okay, ginagawa mo dito. Okay, so ganito, before kasi, so honestly, nung nag-start pa lang, halos yung mga questions parang random lang, no? So walang format. Pagka nagtanong ako, parang halo-halong kalamay tatanong ko. But now, pwede mo pala siyang i-summarize into 3 big groups. So when assessing a patient, I suggest, ito, pwede mong gamitin or you can use your own or others. What we call a map. No? First, assess yung mobility ni patient. Is the patient ambulatory? Kaya ba niya maglakad mag-isa? Pag naglalakad ba siya, may kasama? Pag naglalakad ba siya, confidently, kaya niya maglakad on hallway? Kamusta yung performance ng mobility niya in a familiar and foreign or unfamiliar place? Next, activities. Is your patient still able to do yung activities na ginagawa niya before? ADLs, no? How about eating, bathing, toileting, dressing, transferring, continence? Is your patient still able to do those activities with the given visual impairment? Lastly is participation. So, patient ko ba nakakapag-participate pa in different events? Family gatherings, religious events, ano pa ba? Nakakagimik pa ba siya? May nightlife ba yan? Diba? O kanina, nakakarampa pa daw ba? Okay. So yun, diba? Pagka nag-classify tayo ng ganyan kasi, mas organized yung assessment natin, yung thought process. So now here, so this is the typical clinical low vision assessment flow. Okay? So in this order, we usually do yung assessment. We always start, same din, typical clinical assessment. We always start with case history taking. Okay? Battery ko ba? Ayun na. Yan. So case history taking. Ba, when you do your case history taking, similar din kung paano ginagawa in typical na case history. Diba? Ano yung mga usual questions that you ask? Or yung mga preliminary questions that you ask during case history?
Ocular history.
Ocular history? In specific, pag ocular history.
Na-injured na ba ikaw?
Na-injured? Na-injured na ba ikaw? Ba't ganyan?
May history ka ba?
May history ng alin? Okay, so same din naman siya, same din ang format, no? But in low vision assessment, we give emphasis dun sa task-related history. Okay? Kasi task-related history will give you an idea if your patient is still functional pa or hindi. Okay? Task-related history will give you an idea if your patient is visually disabled or hindi. For example, patient has, let's say, ARMD. No? ARMD. Ano ang obvious na visual impairment with ARMD? Central visual field loss. Okay? Pagka task-related history, ano po ba yung mga bagay na nagagawa nyo ngayon, no? Or yung hindi nyo magawa ngayon? For example, dati kaya pa niya magbasa ng book. Ngayon, Doc, hindi ko na kaya magbasa ng book. Okay, ano pong ginagawa nyo para ma-overcome yung disability? Doc, napansin ko kapag nasa gilid, mas nababasa ko siya. Example, ito. Hindi na kaya. Doc, pag ganito kaya ko, paano yan? Right? So, ang tip dito sa case history taking is give more time, be more specific, okay? Ask specific questions para yung answers din more specific. Okay? Kasi ganito, management, everything will come from the needs of your patient. So, of course, di ka magbibigay ng management kapag wala namang kinalaman sa difficulty ni patient. Di ba? So, that's it. Other details, di ba? Usually, patient will give you yung clinical abstract, medical history, so wala na halos problema. Practical example, kunwari ganito, ang patient pumunta na walang kahit anong abstract, usual na ginagawa, pwedeng pahanap sa hospital, okay? Or pwedeng pa-refer muna. Bakit? Kasi pag nag-assess ka ng walang proper supporting documents, medyo mahirap. Diba? So better na pag nag-low vision assessment ka na, given na lahat ng supporting documents. Okay? Clear tayo dun, guys? Next. Next is visual acuity taking na. So your VA test. Wait lang. Visual function, but alone does not properly quantify or classify a patient's dysfunction. So ibig sabihin, ito yung pinaka madalas na test na ginagawa natin sa patients. Tama? But alone will never or will not give you enough information kung si patient ba is dysfunctional or hindi. Kung si patient ba ay disabled or hindi. Okay? For example, nag-test ka ng VA and nakita mo good pa yung VA. Pwede mo bang i-judge agad na si patient ay okay siya? Walang problema? Hindi. Kasi there are other visual functions. Kunwari, okay ang VA, pero ang contrast is hindi. Poor ang contrast. Poor ang contrast, hindi siya makabasa ng prints, hindi siya makapaglakad sa outside places. Nahirapan siya. Okay, that's it. So, mamaya pa. Next, there are several methods for testing visual acuity. No? So, yung charts natin, mamaya papakita ko sa inyo. We have Leah, we have Bailey-Lovie, we have Snellen, we have Paine-Bloom. So, depende sa need ni patient, depende sa ability ni patient, yung chart na gagamitin. Okay, so mamaya magkakaroon tayo ng actual na sample kung paano yung sa VA. Next, never rely on someone else's measurement unless you know what circumstances it was measured. For example, patient is a follow-up. Tapos nakita mo meron siyang findings agad. Let's say 20M at 1 meter. So 20M at 1 meter. Now, question is, magre-rely na ba ako dito or hindi? Hindi. Bakit? Bakit hindi ko pwede i-consider na hindi ko na i-test yan? Okay na yan, Doc. 20M at 1 meter yan. Okay na yan. Wala na problema. Same na yan. Same. Bakit hindi pwede? Or bakit hindi maganda? Ano yung mga factors? Yes? Pang-measure. Okay. Number 1, distance. Okay. Reliable by distance na ginamit niya. Same. Sure ba talaga siya na 1 meter yon? Next, lighting. Optimal by lighting na ginamit niya. Diba? Baka mamaya naman yung 20M sobrang bright na nasisilaw yung patient, or baka naman nag-over na yung illumination, maganda na than yung actual. Next, patient ba is relaxed dito or baka naman straining na? Baka para mabasa niya yung 20M, parang 10 seconds bago siya magsabi ng another word or another letter. So there are number of factors to be considered, no, before taking yung VA. Dapat sure kayo. So best advice, gawin mo na lang uli, confirm. Always confirm yung findings. Never rely on someone else's findings. Okay? Alright, so next is, alright, so still at VA, determine the best corrected acuity with refraction. So with your visual acuity, you determine yung BCVA. Of course, after refraction. Okay? Monitor the effect, progression, and treatment of a disease. So this is also this is not just limited sa optometrists but also with ophthalmologists, with MD, and other professionals. Kasi 'di ba? With VA, pwede mo makita if the patient is doing better or same lang or worsening. For example, last year 20M at 1 meter. And actually nangyayari rin, no? Tapos na nag-follow up ka, tinest mo uli. Ikaw yung last year, then ikaw uli ngayon. Nag-test ka uli, nalaman mo ngayon na yung 20M at 1 meter nag-iba na. Let's say at 1 meter, hindi na po. Naging 0.5 meter. So with VA, so previously at 1 meter yan ha. Now, naging 0.5 meter, 50 centimeters na lang. Mas umikli yung distance para mabasa mo. Can we say that the patient's condition is worsening? Yes, pwedeng guide, no? Pwede na siya maging reference to. Okay? Verify a person's eligibility for tasks such as driving. Alright, so this one pertains with visual disability. Diba? With VA, you can see or you can assess if the patient is able or unable to do a specific task. Right, with driving. Diba? Can your patient still drive with a VA? With that VA? Hindi na. With independent walking, depende. With eating, so on, so forth. Okay. Maliwanag ba or gusto nyo patayin yung light? Okay lang? Sino sisilaw? Okay lang? Alright, so next. Classify patients as legally blind for the purpose of government, insurance, or other benefits or exemptions. By the way, review. What is legal blindness? 20 over 200. Okay, so it is best corrected visual acuity of what eye? Good eye. Okay, the better eye, good eye. 20 over 200, 6 over 60. Okay. What else can we say about legally blind people? Common ba na naririnig yung term na yan dito? Hindi masyado. Hindi masyado. So, yung term na legal blindness is commonly used in government purposes. Benefits, insurances, no? Kasi when you call a person legally blind, baka kasi ma-confuse with other terms. Partially blind, ano ba yan? Legally blind? Totally blind? So usually ginagamit natin siya pagka sa government. Kaya hindi siya masyado naririnig. Okay? So visual acuity, any questions? Mamaya yung actual na charts papakita natin. No? But now, any questions? BA? By the way, we use yung M units dito. No? Kapag ka nag-start na kayo ng assessment, gumagamit naman kayo ng M units. Yes? Di ba masyado? Okay, so mamaya discuss natin bakit M units. But in this practice, we use M units instead of Snellen. So, discuss ko bakit better ang M units mamaya. Okay? Any questions for VA? Wala naman. Next, refraction. Okay, now. Very important part. Okay? Kung sa normally sighted individuals or patients, mahalaga na ang refraction, mas lalo na dito. Okay? Si patient, onti na lang ang remaining vision. Visually impaired na siya. The more na kailangan, precise ang refraction mo. Okay? Establishes an important baseline from all which, baseline, from all which medical, surgical, and optical decisions follow. So when you refract a patient dito, okay, pag ni-refer natin siya sa other institutions, hospitals, eye centers, titignan na refraction mo. Then from there, pwede silang mag-base ng judgment nila. Si patient ba is okay for surgery? Patient ba is meron pa bang chance na luminaw ang vision niya based sa refraction ni Doc sa RBI? Measure degree of ametropia. Of course. Best corrected VA. Sensitivity to blur, effects of glare, and quality of fixation. So take note, diba, when we refract a normal patient, ano ang pinakamadalas nating goal? Diba? Yung clarity of vision. Diba? Pag nag-refract ka, typical na patient, gusto mo malinaw yung paningin. Next is, of course, dapat komportable siya. Tama? But when you handle a low vision patient, there are other things to consider pa. Next is sensitivity to blur. Pag nag-refract ba ako, kaya ba niya ma-differentiate yung plus 50 with plus 1? Sensitive ba siya dun sa blur na yon? How about plus 50 and 150? Meron bang pagkakaiba? Kasi you will encounter patients na wala na halos pagkakaiba yung small increments ng lenses. Kuha yon? Yes? Next, effects of glare. Doc, pag nakasuot yung salamin, pagka tumingin ako sa chart, nakakasilaw. Paano yun? Diba? Glare, sabi natin kahapon, not only produces discomfort, but might also cause yung decreased VA. Diba? Decreased VA, decreased contrast sensitivity, yan yung effects ng glare. So, when you refract a patient, be aware, be sensitive if there is a possible glare source. No? One example for dito is yung position ng chart. Diba? If you position the chart na medyo bright, for example, nakalagay yung chart ganyan ka-bright. No, pag humarap si patient or si patient is against the light, pwede mag-cause ng glare. Okay? Pag may glare na, pwede mababa na yung VA and CS. Therefore, yung performance si patient bawas. With the normally sighted individual, okay lang, walang problema. Kasi kayang-kayang masense. But when you deal with low vision patient, medyo ibang setting. Dito ba, dapat mas may control si doktor. Okay? Dapat mayroon kang mas control dun sa situation. Next is quality of fixation. Meron kayo na-encounter na nirefract mo, hindi centric yung tingin niya, medyo nakatingin ng ganyan. Meron ba? Ha? Okay? So sabihin natin, hindi pa siya low vision, doc, pero pag tumingin siya ganyan, ano yung possible condition kaya? Okay, pwede may high amount of astigmatism, no? But for example, low vision patient, okay, when you refracted that patient at nakatingin siya, nakaganyan siya, anong next na gagawin mo? Itutuwid mo ba yung mukha niya or hayaan mo siya? Tingin nyo. Nakatingin siya, ayan. Sige, basa ka na. Ayan, tingin siya, ganyan siya magtingin lagi. Ano kaya gagawin natin dyan? Sinong nagsabing itutuwid ko yung mukha niya, Dok? Pipihitin ko ng ganyan. Ganyan ka dapat tumingin. Taas ang kamay. Wala. Sino nagsabi, hayaan ko na lang yan, Dok? Ganyan talaga. Okay, 1, 2, 3, 4. Meron pa? Yung wala, puro may putok po kayo lahat. Okay. So, diba, with low vision, experience natin, kaya sila naka-eccentric fixation kasi meron ng mali dun sa central vision nila. So, when that happens, you note, patient is exhibiting face turn, patient is exhibiting abnormal head positions, head posture. So, kasi makakatulong sa assessment. Right? So, it's not really that beneficial kung itutuwid mo yun kasi ang makikita mo lang, hindi ganun kaganda yung vision niya. Even with glasses, maaari kung low vision niya. So, best is to know. Okay? So, it's normal. It's quite normal when you note extra information do sa chart. Okay yun. Maganda yun. Huh? For example, simpleng VA, nilagay mo patient is exhibiting a face turn or patient is squinting. No, hindi dahil sa hirap siya but may glare talaga. Okay yun. Lagay mo yun. Okay? Next. Ay, sorry. So, onting background lang sa refraction. Very important ang refraction sa low vision. Okay? For several reasons. The high prevalence of uncorrected EOR in the low vision population is related to several factors. So, based dun sa topic yesterday, yung first topic, diba? Prevalence, yung numbers, statistics ng low vision, mga ilang percentage ba yung EOR, refractive error sa low vision population? About ilan? 42, 43, I think. Pero siya yung pinakamalaki pa rin, right? Malaki pa rin ang number ng EORs na considered as low vision. So, ito yung mga possible reason. Okay, number 1, certain ocular disorders such as pathology, cataract, myopia, diabetes, okay, have characteristic refractive findings that are under-detected. So, may mga patients tayo na, yes, may EOR, but meron pa palang underlying condition. Okay? Myopic. Pumunta sa'yo. Nakalimutan mo tanongin, yung pala may diabetes pala. Bumalik, hyperopic na. Okay? Nangyayari? Yes. Next, in conditions such as diabetes and cataract, mas mabilis yung progression. So, there are certain conditions or certain cases na mas mabilis mag-evolve yung refractive error. Okay? So, napabayaan, pwede naging low vision na sila. Next, patients may have come from settings where refractive care is not emphasized. Acuity has been overlooked or dismissed as hand motion or finger counting. We still do this, right? HM, finger counting, counting fingers, yes? But ang question ko ganito, useful ba yan sa low vision setting? For example, HM at 1 meter. Diba? Usually, ganyan ginagawa natin. Pagka yung tipong pinalapit na, hindi na kaya ni patient. No? But my question is this useful in the low vision setting? Yes or no? Yes. Okay. Right. So, paanong yes? Anong information ang may extract natin dyan? Kasi, diba, visual acuity can also be used for magnification. Diba? For example, ang patient ko is nasa 20M. Then, ang gusto niya mabasa is, let's say, 5M. Magkakaroon ako ng ilang magnification dapat, mga 4 times. That's it. But how about HM? Paano ko mako-convert ito ngayon? Ano ang equivalent nito sa M unit? Doon, let's say 5M din. Okay, so ang kamay natin ganyan. For example, hindi ka pwede magpalaki ng kamay para masabi nag-magnify siya. So now, ano ang sense ng HM? Saan pa natin siya pwede pasok? Diba? Yun yung question. Yun yung problem natin. Kasi with hand motion, hand movement, qualitative lang siya. Okay? There is no way to convert HM to a quantitative value. Kaya nahihirapan tayo paano siya mabibigyan ng sense or ng importance. So, yun yung problem. Kasi for example, community outreach settings, hindi natin nabibigyan ng proper assessment yung patient. So, akala natin HM lang, yung pala, palala na, low vision na pala. Kasi HM can be converted into 20/800. For example, di ba? Hindi niya na makita yung chart. Or 20/1200. Or 20/5000 and all. Pataas ng pataas or pawersan ng pawersan. Hindi natin alam ano yung exact na visual acuity ni patient. Okay, so yun yung problema, yung recording. Okay? Lalo na kapag malalayo yung pinagpupuntahan. Next and last is, many patients who complain of failing vision may have delayed seeking eye care. So, nangyayari yan. Okay? Ayaw niya magpa-check, bandang huli, low vision na siya. And sadly, there are places in the Philippines na sobrang deprived ang tao sa eye care. One example is Sorsogon. Na napunta ako sa Sorsogon, meron doon mga matatanda, 65, 70-year-old, first time lang nila na-check ng mata. Okay, first time na refract. 65, 70-year-old, yun lang, first. Natin alam kung may next pa sa kanila. Okay, so yun yung reality ng refraction. Okay, that's why you should be better in giving refraction to your patients. Clear tayo, guys? Any question? Clear? Yes? Okay, next is ito. Alright, so binocular vision. Okay. May form na ba? Wala pa. Okay, please get one and pass. One and pass. Alright, so next is binocular vision. So, kuha kayo dun sa folder, sa envelope, no? May form tayo dyan. So, this is the form that we will be using in RBI. Ito yung low vision assessment form. You can take notes. Alright, so binocular vision. So patients tend to adopt a natural head position and gaze direction binocularly, which more closely reflect their real life posture. So take note, guys, yung real life posture. When you observe an abnormal head position, okay, face turn, head tilt, take note. Kasi clue yun kung paano sila mag-perform or mag-function in real life tasks, situations. Okay? And later on, you can use them as guides in your management. This reveals important information about the compensatory strategies that the patient may have already adopted. So, nag-adapt na siya doon sa impairment, kaya siya nakaganon. Okay? Kaya siya naka-head tilt, naka-face turn. Although normally sighted people are known to have better binocular acuity, diba sa atin? Mas maganda binocularly ang tingin. Diba? Binocular vision gumagana. Diba? In low vision, this is not always the case. So, meron na lahat. So, yan. So, dun tayo sa binocular test. Okay, so makikita nyo either yes or no lang yan. So, may mga test dito. Okay? So, in low vision, that's not always the case na okay yung binocular vision. Diba? Ano bang advantages ng binocular vision over monocular? Depth perception, 1. Ano pa? Dominance. Ano pa? Yun. Wider visual field, di ba? Depth perception, no? Mas maganda yung spatial awareness sa patient and all. Pero, hindi lahat ng cases sa low vision ganoon. Kasi there are cases, lalo na kapag abrupt, mabilisan yung visual impairment, patient siguro nagkakaroon diplopia, patient might be having difficulties with judging yung depth, nagkakaroon ng confusion, no? Kaya may iba, mas prefer nila na i-shutdown yung isang mata or better lang yung isang mata ang gumagana. Okay? So, dapat sensitive kayo sa ganun. So, wag magtataka minsan, bakit ang VA ni Doc pag binocular mas lumala? Poorer na. Okay, assess mo ngayon, anong case niya? Anong visual impairment or disorder meron siya? Okay? So, kung nakalagay dyan, yes or no lang, i-assess mo lang, is the patient still using binocular vision? When we say binocular vision, we pertain to single binocular vision. Or nagsusuppress na ba siya? Or baka may diplopia na yan. Okay? Alright, so more of that kapag nandun na tayo sa sa field mismo, sa pinaka actual taking mismo. But mamaya mag-take tayo ng example. Next is visual field test. Okay? So visual field test very important in visual disorders or diseases such as glaucoma, retinitis pigmentosa, kasi visual acuity sa mga cases na to pwedeng intact. Diba? For example, with RP and glaucoma, visual acuity pwedeng intact yan. Maganda pa. Pero kapag sa visual field ang pinag-usapan, doon pala nagde-deteriorate. Diba? Kaya sinabi natin kanina doon sa earlier slides natin na yung visual acuity is not enough to judge a patient's dysfunction. Kasi you need to assess other visual functions as well. Okay? So to document the visual field parameter of the legal blindness requirement. So visual field is also required or suggested, recommended sa legal blindness category. Okay? Provide objective information about scotomas in the visual field which may explain unexpected poor performance. Pag ang patient pala, kunwari, patient mo laging, let's say, geriatric patient, no? Ang complaint ng mga nasa paligid nga, sabi, itong si tatay laging nahuhulog sa isang side. No? Itong si tatay, pagka tumatama sa lamesa, lagi sa may kanan. Check mo yung VA, okay naman. Nang chinek mo yung mobility niya, yung functionality, motor function, okay naman. Pag check sa visual field, yun pala, may hemianopsia na. Yes? Nangyari? Yeah. So yun, another example on why visual field is very important. Next, patterns of peripheral loss can predict the need to learn safe travel skills. This pertains to your orientation and mobility. Okay? Orientation and mobility, guys. Kapag ang patient, hindi na siya confident na maglakad mag-isa, then it's about time to recommend O&M skills. Okay? Safe travel skills. Yun yung cane, yun yung sighted guide technique, no? Tuturo sa kanya. And influence the plan for rehabilitation. So lastly is to follow disease progression and explain a change in function that does not otherwise correlate with acuity or contrast tests. So, kung ang VA ni patient, ang CS ni patient parehas okay, pero yung performance niya sobrang poor pa rin, 'di ba? Test mo yung visual field. Baka doon may problema. Okay? For example, nireklamo sa work, call center agent. Ito ay actual example. Call center agent, dito sa natin, hindi pa alam ng trabaho niya na meron siyang decreasing visual field. Okay? And natatakot siya na baka matanggal siya sa trabaho. Nagre-reklamo na yung management, yung HR, kasi parang parami errors sa work. So, nang tinest yung VA, okay pa. CS, pwede pa. Visual field, doon natin nalaman na yung mga paligid pala, hindi niya na ma-detect. Kaya madalas sa bumabangga, madalas hindi niya na mamalayan, meron na palang object sa gilid niya. No? So, yun. Okay, so, hindi na-explain ni VA, hindi ma-explain ni CS, but sa visual field, doon lumabas yung reason bakit disabled na yung patient. Right? Question pa? Any question for binocular vision? CS. Okay? Ways to test CS, we have hiding, we have Leia symbols, Leia numbers, yung flip chart. Papakita natin mamaya. But CS is, ito yung important notes. Okay? Usually require more magnification than would be expected by their level of visual acuity. So, balik ako dito. kung ang patient ko, ang kaya niya is 20M, ang goal niya is 5M, typical 4M, 4 times magnification. Pero kung poor ang contrast niya, pag poor ang contrast sensitivity, pwedeng mas mataas pa na magnification ang kailangan niya. Okay? So one of the reasons bakit yung calculations is just used for references. Pero in real life, kailangan mas mag-try out ka pa. So ulitin natin. Kapag 20M and 5M, 4 times magnification. Kapag poor ang contrast ni patient, yung 4 times mo, pwedeng mas mataas pa yung magnification na kailangan mo para maabot yung desired target. Okay? Clear tayo doon? Next, may not be able to read through optical lens at all. So, patients with poor CS, when tested with optical magnifiers, pwede mag-complain sila na, Dok, mas malaki pero hindi ko pa rin mabasa. Yan ang madalas mong maririnig sa kanila. Dok, mas lumaki yung letter pero hindi ko pa rin mabasa eh. Paano ba yun? Okay? Pagka ganoon, check mo CS. Baka poor. Kasi hindi porket na nag-enlarge tayo ng object, automatically means the patient can easily read yung target. Kapag poor ang CS, kahit malaki yan, medyo hindi niya ma-recognize yan. Right? So, paano gagawin kapag ganoon? That's the time you suggest electronic magnifiers. Okay? There are a lot of cases in which yung optical magnifiers or electronic magnifiers mas nakatulong, no? Ang kailangan lang dapat aware ka and alam mo kung paano yung principle niya. So, yun yung sa magnification. Okay? Often benefit from increased illumination when performing near tasks such as reading. So, lighting, improved lighting can also be used as a tool for increased contrast sensitivity. So, automatic yun. Ang relationship lagi, kapag lighting, so yung lighting, improved lighting, ibig sabihin optimal. Hindi yung sobra-sobra. Okay? When you improve lighting, pwede rin na mag-improve yung CS. Okay? So, note natin, kapag mas mababa yung CS, okay, pwedeng mas mataas yung magnification na kailangan niya. Yes? Okay? For example, ang VA natin is okay. Yung CS, okay rin ba? Lagi bang okay ang CS porket okay ang visual acuity? If visual acuity is okay, for example, stella na lang tayo, 2030. Yes, corrected, 2030. Does it automatically mean that yung CS is okay din? No. Okay? So, hindi pa rin siya enough na clue na okay sa CS. Kasi there are cases na okay ang VA, tapos pag-test mo ng CS, dun pala may problema. Okay? Yan. So, any questions for CS? Yes?
Dok, paano po yung magnification sa CS? May formula po ba doon or magta-try ka na sa
Magnification na related sa CS, mamaya may papakita ko sa inyong helpful na table. Okay? As a guide, para malaman natin kung ano yung relation ng CS, not just to magnification but also with reading rate. So may relation din siya. So good question yun. Kasi pag pumasok mo tayo sa CS, mas makikita nyo bakit isa sa pinaka-importante ng visual functions related sa everyday task. Right, so what else? Superior binocular contrast sensitivity performance. So CS and binocular vision. Okay? May mga cases tayo na, so pwede nyo basahin, but explain ko nyo. So may mga cases tayo na yung VA medyo magkaiba. Right? In which, pag tinignan mo, hindi possible na magkaroon ng binocular vision. But CS can also be used as a fusional lock. Fusional lock. Ibig sabihin, pag okay ang CS, mas nakakapag-fuse yung images, mas nakakagamit siya ng binocular vision. That's yun? Kuha yun, guys? Okay. Pag nag-improve ka ng CS, pwedeng mag-improve din yung binocularity ni vision. Following contrast sensitivity over time may reveal unexpected stability or deterioration that might otherwise be detected by visual acuity testing. So, mali yung spelling, so review dapat. Yun nga. For example, visual acuity, okay siya palagi. Right? And doon mo nakikita sa CS na dahil siya nag-deteriorate. So that may also be used as a clue dun sa disease ni patient, yung progression. Diba? So one example yung kanina, let's say yung example natin ni patient, nagbigay tayo ng glasses, nagbigay tayo ng magnifiers, without considering yung contrast sensitivity is getting poorer. Over time, so, yung glasses and yung magnifiers useless na. All because yung CS is nakalimutan test. So when contrast testing reveals a significant deficit, there are three options. So quick guide, paano gagawin ko doon kapag mababa ang CS ni patient? So you can improve yung lighting, better lighting. So yung illumination, task lighting, in position ng object. Enhance contrast. So instead of using yung regular print or regular paper, okay, we can also use yung bold line paper. Instead of using yung ball pen, pwede kang gumamit ng broader or yung broad marker, dermatographic pen to improve yung contrast and magnification, of course. So pag hindi na makita, magnify mo. So check natin lahat yan kung mag-i-improve yung performance ng patient. Okay? Questions pa? Questions pa guys? Wala naman? Okay pa? Okay. Next is after CS, near vision na. Okay? Paano ka magte-test ng near vision? Paano pag pinabasa mo si patient? Paano mo masasabi na yung line talaga na yun, yung nire-record? Kinukuha mo ba yung smallest na nabasa niya? Or yung komportable siyang basahin? Yung, paano ba? Paano mo masasabi na yun na talaga yung best line na nabasa ng patient? Okay, yung working distance. Anong working distance? Ano meron? 40, okay. At 40 cm. Ano pa? Ano daw meron? Paano kang patient ko, nagbabasa siya per letter, ang tagal, sobrang tagal, pero maliit. Kukunin ko ba yun as yung line na nabasa niya or hindi? Okay. So, when dealing with near visual acuity, okay, we want yung smallest, but yet yung comfortable na line na nabasa ng patient. So, we don't want yung line na nag-strain siya, nag-effort siya, kasi hindi naman useful yun sa real-life situation. For example, yung patient, nagbabasa per letter, 5-10 seconds each letter. Can that patient use yung near vision for reading? Okay. Kahit pa 1M yan, kahit pa 1M yung size, pero kung hindi niya mabasa ng matino, ng fluently, effortlessly, useless yun. So aim for the line na comfortable sa and still efficient siya mabasa. So yung pag-clear nun sa kanya. Alright, so in low vision, we record near acuity as the smallest size of print that can be read fluently and easily. Kalagay na pala. When a patient begins to struggle with print, it is too small. Okay? Ito yun. Pagka nag-struggle na siya, wag, awat. Angat ka na isang line, check mo ulit. Use reading cards specifically designed for low vision. So, diba sa school, anong madalas natin ginagamit for near VA? Reduce Snellen, Hira, Jaeger chart, no? So yun dalawa. But in low vision, alam natin na there are number of cases na hindi na useful yung cards na yun. Kasi maliit na. Kailangan nila mas malaking reading sizes or types. Okay, so there are designed charts for low vision. So yun yung gagamitin natin. These include paragraphs of continuous text instead of lines or isolated symbols. So mamaya, tackle na rin natin yung reading rates, no? Instead of single line lang, meron tayong charts na isang buong paragraph yung papabasa kay patient. Para ma-establish natin kung nakakapagbasa ba talaga siya or baka naman teka-teka na yan. Okay? Generally, the reading cards are calibrated in meter equivalents. So those are your M units. Instead of Jaeger or point sizes to simplify calculations for magnification. So, honest question. Natatandaan pa yung magnification? Kunti na lang. Okay, ano natatandaan pa sa magnification? Para alam ko lang yung inatakil ko mamaya. Achieve over goal. Okay. So, good news. So, hindi naman tayo masyadong mag-focus dun sa lahat ng mga formula Velasco kasi ang goal natin is makapag-patient kayo na maayos. So, computations are only used for reference. So, good na alam mo siya, okay? Magandang alam mo siya, magandang kabisado mo siya, but not all the time magiging useful siya sa actual patient. Kapag haba-haba ng compute mo, nakita mo 2.5 or 10 times magnification, okay? Hindi lahat ng pagkakataon eksakto yung computation sa actual. So, they are only used as references. Okay? So, pero kailangan natin tao. Okay, so another thing about Jaeger, no? So, in references, sinasabi nila yung Jaeger chart is unreliable when we convert it to regular sizes ng text. Okay? Kasi inconsistent. No? Kung mababasa mo, meron mga references na nagsasabi yung Jaeger's chart kasi hindi mo or nagbabago-bago or hindi ganun kadali i-convert sa regular sizes. For example, books, sa medicine, diba? Sa newspapers, iba-iba. So kaya mas nasa evidence tayo. So, meron pa bang issues or hindi pa clear na topic sa near vision? Anyway, mamaya idadaanan naman natin. But ito ay overview lang. So after near vision test, next is magnification na. So magko-compute ka na. And honestly, ginagamit natin kadalasan is ang sheet over goal lang naman din halos. Kaya lang may considerations. Okay? When you compute for magnification, you also consider other factors. For example, CS ba ni patient? Okay ba? Yung target ba na binabasa niya? Reliable ba? Ano ba equivalent sa M unit? Kaya, lighting, yung position ba? Environment, optimal ba? Kasi baka mamaya mag-compute ako ng magnification, yung pala lighting is poor. Yung position pala, nasa kaduluduluhan pala siya. So, yun. After computation for magnification, you will try out. Diba? So, try out na. Doon sa form, kung makikita nyo, sa near vision, meron different parts. Una, without distance spectacles. So, unaided. Completely unaided near visual acuity. So, nakalagay right eye, ano yung size, and kung gaano kalayo. Okay? So, hindi pwede maglagay ng VA nang wala yung distance na nabasa. Next, what is the visual acuity with habitual correction, habitual distance correction? So, yun yung pangalawa. Right? Next, how about with your current refraction? Ano yung visual acuity niya? And kung meron bang ginagamit na magnifier si patient, patest mo rin. Okay, so lahat ng yan para magbigay ka ng clue sa'yo kung okay pa ba yung near vision niya or kung may changes. Okay, later on pwedeng gamitin as clue in caring management. So, nasa baba rin yung reading rate. Okay, so mamaya short topic about reading rate and writing rate para at least alam nyo mag-compute, correlate. So, writing speed kasama rin. Very useful kapag ang patient natin ay bata, student. Kasi aside from visual acuity, mas concerned tayo kung nagagamit ba niya yung visual acuity na yun for reading. Diba? Since your patient, for example, is a child, a student, so you want to assess, to make sure na yung everyday task niya is addressed, which is reading. No? When you handle a low vision student, child, no? Very important to assess yung reading rate. Of course, kung nagbabasa pa siya. Kasi there are cases na maliit na yung nababasa ng patient pero hindi pala siya makapagbasa ng maayos. Let's say nagbigay ka ng stand magnifier or hand magnifier. Nababasa niya is 1M. Okay? Tapos ang kailangan niya lang pala basahin is 1.25 or 1.5M. So better than yung goal acuity niya. Pero nalaman mo kahit maliit yung nababasa niya, hindi niya mabasa ng mabilis. Therefore, nahuli pa rin siya sa class. Okay? So, visual acuity hindi pa rin enough. So, you need to assess yung reading rate ni patient. Okay? So, more of that mamaya pag nagkaroon pa tayo na hands-on. After that is magnification na. So, you will try out. So, dito, yung part. Diba? So, you try out magnification. For example, we establish a 4 times magnification. 4 times from what kind of optical device? 4 times from hand, 4 times from stand, dome magnifier, 4 times from spectacle magnifier. Saan ba yan? So in this phase, you want to assess to make sure saan yung pinaka-efficient si patient? Saan yung pinaka-madali siyang masanay, magamit, no? So yun yung gusto mong malaman. And yung ease, yung comfort ni patient is na-address din. So that's the trial of optical devices. And lastly, pagtapos na lahat is prescribing. Okay? So when you're done with the computation, with tryout, last thing is prescribing yung lahat nung binigay natin na assessment sa kanya. Okay? So sabi dyan, when spectacles are prescribed as low vision aids, it is necessary to inform the patient about reading distance and distortions. Okay? So reading distance and distortions. So lens tayo. Usually, with reading distance, ano ang importante mong dapat i-take note? Pag pinag-usapan ng reading distance kay patient. For example, ang patient ko is an elderly. Okay? And gusto lang naman niya magbasa ng mga sizes, yung mga text messages. Ano kaya magandang magnifier para sa kanya? From time to time lang, spot reading lang. Tingin nyo. Wise ba na lagi siya magsusuot ng glasses para magbasa, tatanggalin ulit niya? Or baka naman magnifier lang? Diba? So yun, reading distance, very important. For example, your patient is a student. No? Sabihin natin grade 3. Okay? Ang dapat niyang basahin, let's say 1.5 m. For example lang. Okay? So yung 1.5 m doc, nabasa na niya with optical magnifier. Let's say suspect. Sa hand magnifier. Sa stand.